Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about tuberculous choroiditis, how tuberculosis infects the choroid layer of the eyes, and what are the manifestations and how it can be diagnosed and its possible treatment. This is the fundus photograph of a patient, right eye. Here you can see that there are subretinal lesions throughout the posterior pole, and they are also in the macula, not exactly going into the fovea area, but they are diffusely distributed in the posterior pole. The vision of the patient was not that much affected, almost 6/18, and the blurring of the vision was there, and he had these lesions which can be seen in the right eye, posterior pole, and even the inferior subretinal yellowish lesions. This fundus photograph, the photographer has gone inferiorly and he has taken photographs of the inferior part, that is along the inferior temporal arcade and the inferior part of the retina. So these are even crossing the infratemporal arcade. Yes, and they are quite confluent now with dispersed subretinal yellowish lesions. The right fundus photograph of the same patient. Here you can see there are chorioretinal scars. It shows an old infection which has healed, and so after that the patient developed this scarring which is occupying the posterior area, crossing the infratemporal arcade also, and sometimes when there is a recurrence and infection comes back, we again see sometimes the yellowish subretinal lesions along with these chororetinal scars, which are the old healed scars. So this is the left eye of the patient. So mostly it is showing the old infection, chororetinal scars, but basically the right eye which was infected had that lesions. Another fundus photograph of the left eye. Here you can see that photograph has taken of the superior to the supratemporal arcade and going up to the temporal side, scarring over there we can see, and the fresh lesions are not that much evident in the left eye, which we can say that these are prevalent along with the old scars. No, I cannot appreciate it here, but at least in the right eye they are definitely present over there and that were affecting the vision of the patient. To make a comparison between the left eye and the right eye, in one eye you can see the scarring, old healed infection, chororetinal scars, and they are occupying the macular area, central area also being involved, while in the right eye they are confluent and scattered areas of subretinal yellowish lesion showing the tuberculous choroiditis picture. Basically the OCT and FAS. OCT and FAS basically shows us RPE layer and beyond that. Yes, so if you see please that one and concentrate, there is hyperreflective and hyporeflective areas showing in the left macula where there is scarring over there, damaged areas which are seen in this OCT and FAS. This is OCT angiography. And basically, as I mentioned, indocyanine green angiography is the best investigation to find out these granulomatous changes going on in the choroid. But even these, in OCT angiography, we can also see the hypoxic areas at the level of the choriocapillaris. If you concentrate on the small boxes over there, which are shown at the choriocapillaris, you will see hypoxic areas. Even in both eyes you will see, yes, right eye as well as left eye, those hypoxic areas are there. Yes. Another pattern of photography by Optos showing us a wider view, and it shows that the lesions are basically confined to the posterior pole. They are not going up to the equator and basically involving the posterior central areas in this disease. Otherwise, if you see the periphery, that is spared to a great extent. This is the OCT macula of the patient's right and left eye. If you please concentrate on the right eye, at the vitreoretinal interface there is some hyperreflectivity. If we go towards the RPE, sub-RPE level in the right eye, we will see some elevation, some RPE like Duzenite-like appearance over there. I'm talking about the right eye here. Are present that sub-RPE, Duzenite-like appearance, and some changes are also there going on in the choroid, but these changes in choroid can be confirmed only with ICG and angiography. Now coming towards the left eye macula, yes, because of scarring, everything is distorted over there, and you can see over there that the layers are how much they are distorted. There is no macular edema even in the left eye, which has got the extensive chorioretinal scars because of the old infection. We know that tuberculosis is basically caused by the mycobacterium infection, and to the choroid, its route of infection is hematogenous through the blood. But how we can diagnose this? This is an issue about this. We can do PPD test, skin test, and apart from this we can also go for the quantiferon. We can do chest x-ray, CT scans, and apart from this, if we talk about the PCR in the aqueous fluids, its quantity is not that much, number one. And number two, that there are still concerns about the sensitivity and specificity of the PCR, especially when we are talking about the aqueous fluids. So basically it is the diagnosis of this type of tuberculosis is made on the supportive investigations which we do, PPD, quantiferon, and the lesions in the posterior pole. They are very much helpful. Patient history is very important in that aspect. Previous history, previous infections, and ESR and inflammatory signs over there. These all things help us in diagnosis of the tuberculous choroiditis. And once a diagnosis has been made, then we have to be in touch with infectious disease department. Yes. The case should be discussed with infectious disease department, and after consideration and consultation with them, these patients can be put on anti-tuberculous therapy, which is isoniazid, rifampicin, pyridoxine, ethambutol. And under the umbrella and under the coverage of these antibiotics, these patients, if there is, as I mentioned, activity, inflammation is going on, these patients can also be put on the oral steroids, 1 milligram per kg body weight, and once the response is good, every 10 days they can be tapered off gradually. So, but the thing is that these patients need regular follow-up. Regular OCT should be done to see any macular edema, perivascular sheathing, any hemorrhages. In this patient, we could not see in the photographs the perivascular sheathing, hemorrhages, macular edema, no. They're just symptoms that lesions, subretinal lesions with indistinct margins in the right eye, and which are basically involving the posterior pole. Yes, and the left eye we saw this all changes over there. So this type of the treatment is very helpful in controlling the infection. The steroids should only be given under the cover of umbrella and the cover of anti-tuberculous therapy. So this was a very interesting case which I wanted to share with my respected audience, that tuberculous choroiditis may be the first manifestation of the tuberculosis. Yes, and it is very much possible the patient has no manifestations in the body. So during the whole treatment we should be in touch with the medical specialist, infection diseases department, because sometimes we need sputum culture and sensitivity for acid fast bacilli, gastric washouts, urine samples for the detection of these samples. So this is basically a team approach in these diseases to cover and control the infection. Yes, I hope this presentation will be beneficial for my respected audience in the management of tuberculous choroiditis. I want to thank you for your attendance and attention. Thank you.